I would like to thank our head of department, Professor Yashpal Sharma, and Professor Rajesh Vijayvargiya for guidance during this study. Anthracyclines are a main part of chemotherapy regimens for various malignancies, including Hodgkin's and non-Hodgkin lymphoma. The main challenge of their use is cumulative dose-dependent cardiotoxicity. They do it by the following mechanisms are shown to generate oxidative stress due to excessive free radical generation, and they do modulation of topoisomerase 2 beta 2 activity, which leads to DNA damage, and they do also alteration in membrane transport system. Cardiotoxicity, the lead of study, cardiotoxicity, when detected by remarkable fall of LBF by echocardiography, it already has reached the advanced disease and it should be with very poor outcomes. So presently increased interest for early detection of cardiotoxicity, however, there is no consensus regarding which approach would be best to detect cardiotoxicity in subclinical stages in order to prevent overt cardiotoxicity. Other modalities available are 3D echo, MOGA scan, biomarkers. However, their routine use in asymptomatic oncology patients is limited mainly due to lack of sufficient data supporting. Global GLS by 2D echography Speckle technique measures strain in multiple left ventricle segments and has shown detection of early myocardial damage even when the ejection fraction is normal in these patients on chemotherapy. Similarly, cardiac biomarkers have shown diagnostic efficacy in early prediction ahead of clinical onset of cardiac dysfunction in some studies. So, this study was planned to estimate whether the use of GLS by 2D echography and serum cardiobiomarkers could detect early myocardial involvement before global alveolar function deteriorates in the patient with lymphoma on anthracycline-based chemotherapy. Objectives were to estimate cardiotoxicity, to estimate subclinical cardiotoxicity, to estimate changes in the levels of troponins and BNP from baseline. We included the patient in this study from February 21st to June 22nd at PGI, and included the patient newly diagnosed case of lymphoma and age were more than 14 years. Exclusion were EF less than 50%, suboptimal echocardiographic images, and CKD stage 4 and 5. Ethical approval was taken from a committee. All patients were underwent ECG, echocardiography, serum cardiac biomarkers at baseline and after 3 cycles of chemocycle, that is V2, and at the end of chemotherapy at V3. So 56 patients were evaluated for eligibility and 51 were enrolled as 4 had poor echo window and 1 was of CKD, and 40 patients completed the study as 9 died during visits, and in the 2 cases it needs to change the regime. The definition, the cardiotoxicity was defined as LVF drop more than 10% to the value less than 53%, and subclinical was defined a decrease of 50% compared from the baseline. The mean cumulative doses of doxorubicin at a baseline was 0, at second visit was 153.75 plus 170, and final visit at the end was 290 plus minus 15.75. These were the baseline characteristics. The mean age was 42, and the age more than 65 were on 12.5% cases, and the 55% male and female were 45% of the cases, and all patients only of Hodgkin lymphoma, non-Hodgkin lymphoma were taken. And when we compare the serially at every visit, these 3 parameters shown the trends. The GLS at shown the decreasing trend at first visit, second, third visit, and troponin and biomarkers both shown increasing trend. The cardiotoxicity as per predefined criteria it was reported in 7.5% cases, and the various parameters at baseline in patients treated with doxorubicin who developed cardiotoxicity are shown. So the patient who developed the cardiotoxicity were more elderly. The mean age was 63 and had a more prevalence of diabetes and hypertension in these cases. The rest of the parameters were not significant. Similarly, the echocardiography parameter were compared at the GLS at second visit, that is after 3 cycles, shown downtrends and was significant. And also when we calculated at V2 change of 50%, that also came out to be a significant in this our study. So the subclinical was 70.5% as a dose of 290, and 1 patient developed at the dose of 153, and rest developed at 290 at the end of study. This is a figure showing how the pre-treatment and post-treatment fall of GLS, while the EF ejection fraction remains same. So when we use the GLS for prediction, the threshold of 18.1 show at second visit shown the sensitivity 100 and specificity 73%. And the GLS, when we calculated the change was 15%, it was also sensitivity shown 66.67% and specificity of 97.3%. Discussion, we evaluated the patients at the baseline visit, then at a second visit, and then at final of 290 plus minus 50 milligram per meter square. None of these patients received other cardiotoxic drugs like trastuzumab, radiation, thus avoiding confounding factors while interpreting the results. So, clinical cardiotoxicity was developed in 7.5% of cases, and which was in consensus with the existing data. And the subclinical cardiotoxicity developed in 70.5% at the mean dose of 290 plus minus 15.7 milligram per meter square. And similarly, the change in GLS more than 50% after just after three chemotherapy cycles compared to the baseline identifies the high-risk patient for development of cardiotoxicity with a sensitivity of 66.7% and specificity of 97.3%. And when the at an absolute number we calculated, it was came out to be minus 18.1 for prediction of cardiotoxicity at the end of chemotherapy with the area under curve for 0.9 and sensitivity specificity of 100% and specificity of 70%. The levels of both cardiobiomarkers increased respectively from baseline to the end of chemotherapy with treatment. However, change was not statistically significant for the early prediction of cardiotoxicity. The limitation of our study were we didn't follow patient after completion of chemotherapy to detect later type of cardiotoxicity, and the longer term impact of early reduction in GLS is still uncertain, and it was a single standard study and was not blinded. I am concluding. Out of 51 patients, the 40 completed the study. A serial evaluation with ECG, echocardiography, and biomarkers done at baseline visit after 3 cycles and after end of cycles. The serum cardiobiomarker shown the rising trend was not significant statistically. The decrease in GLS to minus 15% or relative change by 50, both were predictive of future cardiotoxicity at the second visit. The GLS suggested cardiotoxicity can be predicted early of its course by measure of GLS baseline and after 3 chemotherapy cycles at a cumulative dose of doxorubicin 153 milligram per meter square. So these results should encourage the physician to use cardioprotective medicine, beta blockers or ACE inhibitors, and to consider patient for early echocardiographic follow-up. Thanks.